Welcome to Journal Journey Maha-IIP with Raigad IIP. August is the month of celebrations. Our country got independence, and in 78th year of freedom, India is making phenomenal progress. And to achieve this, we have Sustainable Development Goal SDG 4 by 2030. Similarly, our collective aim is to equip the practicing pediatricians in periphery with correct knowledge, skills, and guidance through the topics discussed in Journal Journey. The optimal use of social media for mass communication with technology and AI tools can be useful, and these are the exactly things which we are going to discuss in this month. May I invite Dr. Neha Singh, Raigad IIP editor and AHA secretary, for a formal welcome of all the dignitaries. Over to Dr. Neha.
Thank you, ma'am, for the kind introduction. And good evening to all the respected dignitaries, seniors, and my colleagues. I, Dr. Neha Singh, welcome you all on behalf of Maha-IIP and Raigad IIP to the next session of Journal Journey in August. I welcome Maha-IIP President Dr. Sanjay Pakmode, sir, Secretary General Dr. Amol Pawar, sir, State Convener Sanjay Deshmukh, sir, past Maha-IIP President Dr. Hemant Gangolia sir, Meenakshi sir, Raigad IIP President Dr. Vikas More sir, Secretary Dr. Ajay Kohli sir, Dr. Niman Mohanty sir, Jay Bhandarkar sir, and all the respected executive board members of Maha-IIP, Raigad IIP, and all the other branches. I'm extremely delighted to welcome our esteemed experts of today, Dr. Shekhar Dabadkar sir and Dr. Amit Tagade sir, as well as our presenters of today, Dr. Bhakti and Dr. Aditya. Now I invite Maha-IIP President Dr. Sanjay Pakmode sir to please give his blessings. Over to you, sir.
Thank you, Neha. Namaskar. Welcome to this 8th episode of Journal Journey. Let me first apologize on part of Maha-IIP because I think the date of Journal Journey is first time changed from first to second. But unfortunately, it was such a thing. Two programs, I thought on the different means permutation combination. Can we do on the different times? Can we do one after other? But then it seems it was very difficult and it was confusing the attendees. So then, I mean, Raigad IIP is, I mean, they are really means I'm obliged to them. Rather, I called Chitra madam also, but madam didn't pick up the phone. What can be done? But they agreed. And I know खूप उदार लोक आहेत ते लवकर माफ करतात. So once again, I really means first time maybe the date have been changed from first to second. This will happen in this month only, hence onward it will not happen. This journal journey means project of this real means of Raigad branch with a lot of hard work and a lot of efforts. Since last 3-4 years, they are doing the journal journey, and it is a wonderful thing, a very hatke activity, where means other academic activities and this activity are totally different. In other activities, we are talking on some subject, but here we go to some journals and the experts present it, then the expert give the comments, and there's a lot of discussion. So it's a wonderful thing. Once again, I congratulate especially the Raigad branch, all the members who are doing the means great work for Maha-IIP, and this should be continued in the future. Let me welcome Dr. Chandrasekhar Dabadkar sir as today's experts. After so many days, we are meeting online with sir. Dr. Dabadkar sir is a CIP West Zone president, past CIP West Zone president, and very much, I mean, known to everyone. म्हणजे हसतमुख अशा व्यक्तिमत्व. Dr. Amit Tagare sir, Secretary Maharashtra NNF in Sangli. I would have been at Sangli for today. There is a
Yes, sir. We missed you at Maharashtra.
yeah.
And I'm missing the banquet because the date changed.
So, चल कोई तो है सांगली से. And then today's presenter, Dr. Bhakti and Dr. Aditya. So once again, in our secretary, Dr. Amol has also joined, Dr. Sanjay, and all the CIPB, MAHA-IPBs, and all the stalwarts who have joined to the today's meet, and especially not to forget Dr. Niman Mohanty sir, Srinivasan sir, and all the attendees. So over to you, Neha.
Thank you, sir, for your blessings. Now I invite Dr. Amol Pawar, sir, to say a few words. Over to
Thank
you.
you. Thank you. Thank you, Dr. Neha. So first of all, I welcome my Baba, past President, Central IIP from West Zone, Dr. Shekhar Dabadkar, sir, a respected personality all over India actually, and the main founder of Raigad branch. I also welcome my another friend, mentor, Dr. Amit Tagare, sir. He's from Sangli. I was just half an hour back. I was at his NICU, and how dedicatedly he's doing practice as a founder member of neonatologist group of Sangli, and one of the budding pediatrician I met there, as she was a mother of a baby which was admitted from Chiplun, 5-hour journey that baby took in an ambulance, and then that baby is admitted at SIRS Rainbow Hospital in NICU. So much is the popularity of Dr. Amit Tagare sir in this part of the Maharashtra. I also welcome budding pediatric endocrinologist Dr. Bhakti from my own place, Nasik, and also Dr. Aditya Tang. He is a neonatologist. Both the topics are very great. The pediatric obesity in rural settings, and also the other one is neonatal morbidities and the positive health outcome. So Aditya will be talking on this. He is from Amravati, the great city of our experts, Dr. Satish Agrawal sir, Jain Pandrikar sir, and Dr. Satish Tiwari sir.
Yes,
so I also welcome Dr. Niman Mohanty sir, Chitra ma'am, Gangulia sir, Sanjay sir, then all the attendees, and wish you all happy learning. Thank you.
Thank you, Amol, sir. Now I invite Raigad IIP President, Dr. Vikas More, sir, to invite our guests and hello.
Hello.
Yes, sir. Over to you, sir.
Hello. I'm audible.
Yes, sir. Yes, sir.
Yeah. Am I audible?
Yes,
I'm
sir.
traveling from.
You're audible.
Apology for if there is a breaking voice. I'm very much proud to be a part of this team, especially led by Chitra Madam and Niman Mohanty sir. I'm ably assisted by Neha and Vishal. I'm so much grateful to our dear President Pakmani sir and Secretary General Dr. Amol Pawar for their continuous blessing. And at the last, our own Dabadkar sir, to see him as an expert after so many days is a cherry on a cake. I wish best luck to both Dr. Aditya and Dr. Bhakti for the presentation today. And Amit Tagare sir is a very good friend now after Nahanyokma. And it is a great association which will last forever throughout my life. Over to you, Neha.
Thank you, sir.
Thank you, sir. Now I invite past MAHA-IIP President, Dr. Hemant Gangulia, sir, to give his blessings and introduce our experts and presenters. Over to you, sir.
Thank you, Dr. Neha. Good evening to all respected dignitaries on this Zoom dais, as well as the attending delegates, office bearers of MAHA-IIP, office bearers of IIP Raigad, office bearers of AHA Raigad, and our Dr. Niman Mohanty sir, as well as Srinivasan sir, to be on this today's webinar. And Dr. Sanjay sir, you need not say sorry. This is second time it occurred, but it happens. We have to adjust the things. And so it's nothing to say about that. It is on the contrary, it is a we are really fortunate that you are giving us the opportunity on the MahaIP platform. And this is the 5th year of this journey, general journey, we are going through. And so I'm very happy because which was started with IP Raigad, going to the MahaIP in all these states across. Today, I have been assigned the duty of introducing the experts as well as the speakers. And our first expert who has made this IP Raigad to blossom, and the person when he was president of IP Raigad, I worked with him for years as a secretary of IP Raigad. And that person, a great person from a remote place, from a rural place, becoming vice president of the national vice president West Zone in year 2020. And जरी अमोलने त्यांना बाबा सांगितलं, पण आम्ही त्यांना पितामहा, भीष्म पितामहा ऑफ रायगड म्हणतो आम्ही त्यांना. अँड ही इज रिअली टॉर्च where we see everything and we learn everything from him. And he was national vice president in 2020. And also इथे जे लिहिलं नाही आहे, पण त्यांनी छान पुस्तक लिहिलं होतं, चला मुलांना घडवूया हे पुस्तक. आणि he was really passionate about teaching about the parenting and parenting awareness across the state as well as across the country. And so he has organized so many parenting programs in district Raigad. We have the parenting programs and also the workshop for the nursing. This was done. And once and then also he has been awarded with so many awards. And to specify, Jeevan Gaurav Puraskar, Raigad Bhushan Puraskar, Pidya Teresa Award, and he has also been his conferred FIAP at Indore National Conference 2014. So he's a great person, great teacher, great leader, and great friend, and a nice, humble human being. That is
अब रुला देंगे क्या?
So we
बस, बस,
present Dr.
Thank you so much.
Chandrasekhar Dabadkar as one of the first expert. And what is the coincidence that the topic he will be is the managing obesity at a rural setup. So many things we have learned from him to manage in the resource limited settings. And our next expert is none other than Dr. Amit Agare. Already Dr. Amol has spoken great of him, and I have the opportunity of having great interaction with him when we organized MahaNeocon 2024 at Navi Mumbai, organized by IIP Raigad. He is a very sincere, meticulous person, and he really sees all things are there. And he is a director and in charge neonatologist of Aditya Rainbow Super Specialties Children's Hospital. And what work is doing at this hospital has already been enumerated by Dr. Amol in his address. He is secretary of Maharashtra State NNF 2024 and in this current year 25. And he has so many various posts. He is in the National Neonatology Forum, as well as lot of publications. Here it is not showing, but he has lot of publication, lot of presentation in the conferences and in the publications. And so we have the next our expert, Dr. Amit Agare sir. He is a neonatologist from Sangli. So these are the experts who will be for today's webinar, and our great presenters, energetic presenters, Dr. Bhakti Madam. She is a pediatric endocrinologist from the Nashik, as well as she has been attached to Apollo Hospital Nashik, and she will be speaking on the treatment of pediatric obesity in rural settings. And rural settings is very difficult. And of course, when we are doing some activity, Dr. Chitra Kulkarni Madam has given us a book at the rural setting to fill the book and give it return to him. But unfortunately, I have not given that book to her, but she is so passionate about this. So that is the also managing the incidence of the obesity. So she will be speaking on this treatment of pediatric obesity in rural settings. Welcome, Dr. Bhakti Madam. And our next presenter is the Dr. Aditya. He is working as a pediatric intensivist and neonatologist at Dr. Punjab Rao Deshmukh Memorial Medical College, Amravati, and he has been trained everything at in a Wadia hospital, and he will be speaking all about neonatal morbidities, neurodevelopmental issues, impairments in the preterm health of the children who are born before 32 weeks of gestation. So we'll be listening this. Welcome, Dr. Aditya. With this note, I welcome both experts, both presenters to this webinar, and I'm sure with this stalwarts speak as the presenters and stalwarts as experts, we'll be having a good learning session today's webinar. Thank you very much. Over to Neha.
Thank you, Gangolia sir. Now I request Dr. Bhakti to start her presentation on the treatment of pediatric obesity in rural settings. Over to you, Dr. Bhakti.
Thank you, ma'am. I'll just share my slides.
Yes.
Are my slides visible, ma'am?
Yes.
Yes.
Okay. So, good evening, everyone. I'm Dr. Bhakti Kataria Dugar. I'm a pediatric endocrinologist. I have completed my education from Wadia Hospital, Mumbai, and I'm practicing in Nasik now. So, moving ahead, our today's topic for Journal Club presentation is treatment of pediatric obesity in rural settings, identifying and overcoming barriers to care. So, this is a US-based study which has a valuable implication in our Indian setting as well. Authors of this topic are Rushika Roy, Carrie Gordon, and Valerie O'Hara. This article was taken from journal called as Pediatric Clinics of North America, volume number 72, page number 11 to 18. And this is a recent article of 2025, impact factor being 2.3. So before starting, why did we choose this topic for today's discussion? So although this is a US-based study, but the challenges and the problems which they have faced are very remarkably similar to our Indian setting. The solution to these problems which they have proposed are not only acceptable or not only adaptable, but are very urgently needed for our Indian setting. So let's go ahead with our topic today. So moving ahead with the introduction, pediatric obesity is becoming rampant all over, not only in India, but all over the globe. So WHO says that there are over 300 million children and adolescents who are affected with this obesity monster. And of this 300 million, 14.7 million children are there in US alone. So in spite of newer modalities and newer well-developed modalities being introduced for this obesity management, the obesity problem is still rising. It is still sky high, especially in the rural setting because of ineffective delivery of the care. So objectives of today's discussion is to know the current data on implementing pediatric obesity treatment in rural setting, to know what all are the barriers to effective care and what all are the potential ways to overcome them. So moving ahead with the current data. So the current data says that obesity is in the worsening trend. So when it was compared the data was compared between 2020 and 2012, it was seen that 2020 has shown a drastic increase in the obesity worldwide. And it is more worse and more frightening when we see at the rural obesity statistics. So there are higher and more severe obesity rates in the rural setup. That is, the rural kids are obese with grade 2 and grade 3 as compared to that of the urban population. And it is more worse in lower socioeconomic status areas. The rural youth or the kids with obesity in the rural setup has to travel farther to get access to all these modalities. Because of this, there is higher care of the burden. So these are the key barriers for managing obesity in the rural setup. First is lack of access to all the treatment modalities. Second is lack of insurance coverage. Third is limited obesity medical education. Fourth is stigma and provider bias. And fifth is minimal pediatric obesity specific research. So I'll go ahead with all these barriers one by one. So first is lack of access to all the modalities. So we know that for managing obesity, it is not only the doctors, but we need dietitian, we need exercise experts, psychologists, and sometimes even the social workers. So all of this interdisciplinary team is not available for all the patients in the rural setup. So what can we do? Providing services via multiple modalities can help, like telemedicine, video call, video conferences, satellite clinics, and even e-consult can definitely help them. Support of policy to expand telehealth is also very important. So the virtual assessment of all the patients is also very necessary, and the financial concerns for both the patients and the provider is also very necessary in this. Next is support of healthcare system to consider value-based care strategies. So now what is value-based care strategies? So the rewards to the provider should be given based on the outcome decision or the quality care of the patient, and not on the number of qualities or number of services which is provided to the patient. This is what value-based care strategies mean. Our next barrier is insurance coverage. So there is a limited coverage for anti-obesity medications and therapies like behavioral therapy and bariatric surgery. So there are few anti-obesity medications like liraglutide, orlistat, or even setmelanotide, which is a very costly affair, and the rural population just cannot afford this. Also, the current payment model is very tedious for both telemedicine patients as well as in-person patients. So what can we do here? We should continue advocacy for state Medicaid coverage for anti-obesity medication. We should keep pushing the policymaker to include the anti-obesity medications in their insurance coverage as well. Doctors should help in prior authorization and appeal process for denials. The paperwork for the approval of the policy is very tedious. So doctors should always help the patients for this process and appeal if there is any denial. And again, as I said earlier, use of value-based care model for both children with obesity and healthcare team is very essential. Our next barrier is obesity medical education. So I know that obesity was not always there So initially, way back then, it was the underweight or undernourishment, which was the major hurdle. But nowadays, it is not that. Obesity is become rampant not only in the urban area, but also in the rural setup. And because of this, it is not studied much. And hence, there is a limited curriculum across the interdisciplinary medical providers. And here, what we can do is we can provide ECO. Now, here, ECO is extension of community healthcare outcomes and learning opportunities. So, this ECO is a telehealth model wherein they take a video conference with our doctors which are there in the primary healthcare setups or under-reserved areas and help them to manage the patients there. And next is building obesity medicine into formal curriculum for medical students. Not only the medical students, but the nursing staff, occupational therapists, physiotherapists, PhDs and social workers as well. Next thing we can do is the growth of pediatric obesity medicine fellowship we can introduce in our education. Moving ahead with our next barrier is advocacy to address bias and stigma. So first is, yes, there is a lot of bias and stigma, not only in the patients, their parents, but also in the doctors who manage them. So first is we should know what all bias and stigma is there. So the data outline ongoing bias and stigma is very important. Lack of understanding of biologic basis for pathophysiology of obesity is also one of the major hurdle here. So obesity, it is not that obesity occurs only because of inactivity or overeating. Obesity is basically a chronic disorder which can occur because of underlying etiology like endocrine problems, genetic problems, metabolism issues, neurobiological issues, and many more. So one should understand the etiology and pathophysiology behind the obesity to manage it. Next is data highlighting persistence in negative stereotype and stigmatization of patients with obesity by healthcare team. So, you know, there are many negative stigmatization. For example, it is said that obesity is because of bad parenting or it is because of laziness. But this is stigma and we should address that very clearly. What can we do? We can initiate to reduce obesity bias and stigma in the healthcare settings, and we should support for existing efforts to educate policymaker and the public. So moving ahead with our last barrier, which is need for more large-scale pediatric research and clinical trials. So we know that whatever treatment is covered under the insurance company, all those treatments are FDA approved. But obesity is very recent disease and not much of the FDA approval treatment is provided for that obesity management. And hence, and sometimes the FDA approval can take many years, causing delay in access to care. So what we can do here is we can help in funding and we can support to launch the pediatric trials for the FDA approval. Creation of an obesity pediatric task force advocating for this research. So what is obesity pediatric task force? Is a force which has all the clinicians, research, which helps in doing all the pediatric obesity trials. We can opt for that as well. So coming to our study. So this is a study of US from a small rural state called Maine, wherein they have did a multimodal approach and they have done various programs there like Wow Telehealth, satellite clinics, weight and wellness satellite clinic, countdown to a healthy me, etc. And with this approach, they have eliminated patient waiting list. Also, they have created an e-consultation programs for healthcare practitioners, and they have expanded telehealth obesity programs with more robust satellite clinics. And this is data from the same city of state of US, which is a rural setup, wherein they have shown a timeline of national pediatric obesity treatment milestone. So we can see that in 1960, it was only phentermine, which was approved for obese children, that too more than 16 years of age. In 1970, then MBS is metabolic bariatric surgery, was approved for adolescent obese kids. In 2003, FDA approved Orlistat also for adolescent weight management. In 2010, we can see that task force has endorsed lifestyle modifications for childhood obesity. So in 2013, we can see that AMA has designated obesity as a disease. So you can see before 2013, obesity was not even considered a disease. It was just after just some 10-15 days back, it was considered as, it has been considered as a disease. And many other trials. In 2020 now, FDA has approved liraglutide for adolescent weight loss. In 2022, phentermine topiramate combination was approved for weight loss in adolescent. And in 2023, semaglutide was approved for adolescent weight loss. So this is how we can see that how Maine, which is a very small rural setup in US, has improved themselves over the time, which we can also do in our setup like India. So coming to advantages of telemedicine, it has improved insights into patients' home environment. So as we have a teleconsult, we can also see how their home is. Is that everyone in the home is obese or only the child is obese? How is their diet? Is everyone having has a bad dietary habit? How is their lifestyle? Is it a sedentary lifestyle? This is how we can just peek into how they are going through, how their home environment is. Next is ability to include more caregivers in the patient care, like grandparents, caseworkers, behavioral health providers, and others. The next is use of remote patient monitoring to obtain anthropometric data. So I agree that telehealth or telemedicine can be a bit difficult because we cannot we cannot assess the anthropometric measures like weight or height of the child cannot be seen or cannot be measured by us doctors online. But we can always ask our patients to use some remote tools to measure their weight and health. For example, a measuring tape. We can ask them to use a remote tool like measuring tape to measure their waist circumference and just write it down gradually over 2 months, over 3 months. Or the traditional method which we use to monitor a height. We can just plot their heights on the wall and they can then come back to us and they can show their monitoring levels. Next thing is less anxiety during visits for patient with special needs like anxiety or autism. All these kids with special needs cannot always come to us in person to take consultation. Hence, telemedicine can be of great help to them. So coming towards the summary of the finding, obesity is growing like anything in rural youth. It is not only the urban area problem, but it is rampant everywhere. The care gaps persist despite the clinical practice guidelines being developed. Telehealth definitely holds a potential. Policies must evolve very fast and support system to all the kids with obesity is very, very essential. So I know that Journal Club is just about discussing the article, but I feel that we should go one step ahead of discussing a little more about what we can do in our Indian setting. So before going there, let me tell you what are the Indian statistics. So in infants, NFHS 5, that is National Family Health Survey 5, reports that about 3.4% of children below 5 years are overweight, with an increase of around 50% from 2.1% in NFHS 4. While in childhood and adolescent, childhood obesity is as high as 40% to up to 24 times rise in last 2 to 3 decades. So you might have noticed that obesity has dramatically increased after the COVID era. The reason behind this may be the child were not allowed to socialize, they were not allowed to go outside and play. And because of that, they were constantly inside the home, watching TV, increased screen time, eating the entire day. This may be one of the reasons for increased obesity after the COVID era. So of all the obesity, causes of obesity, exogenous obesity is the one which is 90% of times is the etiology of it. So let's discuss a bit about risk factors of exogenous obesity. So risk factors starts from prenatal period itself. So if the mother is overnourished, if she is overnourished, the child's weight increases and there are chances of metabolic syndrome in the child in the future. If the mother is undernourished, the child can have fetal restriction, which can lead to insulin resistance and hence obesity. The gut microbiome, which is rich in lactobacillus or bifidobacterium, is very good and helps in decreasing the risk factor for obesity in the child. Whereas the diet, which is very rich in fat, is always a risk factor for obesity. While diet like soya bean, folate, green tea phenols are very good in preventing obesity in the child, if all of these things are consumed by mother in pregnancy. Coming towards infancy, exclusive breastfeeding helps in reducing the risk factor. I think this everyone knows, and I think August week is the best time to focus more on breastfeeding. While formula feed helps in lipogenesis and hence increased obesity. This one thing I would like to focus a lot, that early introduction of complementary feeds before 4 months of age increases the risk of obesity to almost 6 times. So I think exclusive breastfeeding till 6 months is the best option to prevent risk factors for obesity. Coming towards lifestyle management, I don't think so I have to talk much on that. Everyone knows that food which has saturated fatty fats, which has dense sugars, fried food, snacks, packaged food, all of these leads to increased risk factors for obesity. Along with that, screen time more than 2 hours, poor sleep hygiene, sedentary life can also lead to obesity. And next is the genetics. So there is something known as obesogenic genes, which are the genes other than those genes which causes monogenic obesity, like leptin or LEPR gene. These are different genes, but this obesogenic genes like FTO or PPAR gamma gene, when present with environmental or behavioral factors, have a cumulative effect and can lead to obesity. So can we prevent these risk factors in Indian rural settings? Yes, we can. We definitely can. So how we can do that? First is with the help of telemedicine, video calls, and obesity apps to emphasis on healthy diet and daily physical activity in the entire family is must. Focusing on infant care, as I said, exclusive breastfeeding, avoiding formula feeds, and early complementary feed will also help. Using apps, I think everyone has these apps nowadays in the phone, like to record the screen time, physical activity like Healthify Me, etc. And the sleep routine is also very important. And coming towards the next point, this is also very important. So use of television and social media for responsible food labeling of energy-dense food. So what is food labeling? So we might have seen the ads on the TV, which says like a whole wheat bread or a whole wheat biscuit, etc., which shows that their food is very healthy. But when we see at the food label, we can understand that how much calorie dense it is, how much carbohydrate, how much sugars it has. So I think every ad should be made compulsion to them to show the food label. Along with that, the disclaimer should be given of how really healthy the food is. Next is government schemes. We would like to appeal to government to add yojanas for obesity management, not only the medical, but also the surgical, like bariatric surgery as well. Coming towards the third point is stigma. So our rural setup, people think that being fat is healthy. मेरा बच्चा मोटा नहीं है, मेरा बच्चा तंदुरुस्त है, मेरा बच्चा पौष्टिक खाता है. So I think this is a very wrong stigma which is prevalent in most of the rural setting, which needs urgent addressing. Next is education. Educating physicians about importance of plotting growth charts along with BMI and waist circumference chart to catch obesity early. So this growth charts for less than 5 years, we can always monitor weight for height charts, and for more than 5 years, BMI has to be calculated and monitored. But I understand that in this busy setup, calculating BMI every time is very difficult. But what we can do is at least we can measure a waist circumference and we can plot. There is something more in this, is that there is hip circumference and waist to hip ratio, which is more sensitive marker to catch the obesity. And I think monitoring and plotting once is a good start, but continuing it every 3 monthly or at least every 4 to 6 monthly can give us a good trend of how the child is gaining or how the child is not gaining. Next is that introducing fellowship courses dedicated for obesity is also very important. Workshops, conferences, CMEs, support group meetings for managing obesity can also help us a lot. And next important thing is urgent referral to pediatric endocrinologist if red flag signs of obesity are seen. So in short, I would just like to tell what all red flags are. So very early onset of obesity, excess and dramatic rise of weight, lot of intake of some medicine which is causing obesity, developmental delay, hypogonadism, vision abnormalities, all of these things, or syndromic phase with obesity. And one most important thing is if the child is short and obese. All of these are red flag signs for obesity, which needs urgent referral to pediatric endocrinologist. Next is research. So obesity is always being studied in urban population because way back then it was only a problem or only the hurdle of urban population. But now it is not that so. So there is a very minimum case reports on rural population. We need more large-scale pediatric research and clinical trials in rural setting as well. So thank you everyone for patient listening. I hope I have not did more than my time limit. Thank you all.
Yeah, it was an enthusiastic presentation, Dr. Bhakti. Everybody enjoyed it, and let us know it from expert, his experience about rural obesity and how he has managed for last 40 years. Over to Dr. Dabadkar.
Good evening, everybody. Respected.
Will you please stop sharing, Dr. Bhakti?
Sure, ma'am. Sure.
Am I audible and visible?
Yes, sir.
Yes, sir. Respected Professor Dr. Mohanty sir, Senior Pediatrician Dr. Srinivasan sir, President IMA IAP Maharashtra State Pakmode, my friend Amol Pawar, the person who talked very nicely regarding me. I know मैं इतना बड़ा आदमी नहीं हूँ, हेमंत भाई. Still, who started this program, and he is really my friend, guide, and philosopher from Raigad district, Dr. Hemant Gangulia. Raigad IIP President, Dr. Vikas, Dr. Ajay. Organizers, Chitra Madam, Neha Madam, Jai Bhandarkar, who is not here. Thank you very much, Sanjay, for very good words for me and kind words for me. मैं इतना बड़ा आदमी नहीं फिर से बोलता हूँ. Coming to the point, Bhakti, Dr. Bhakti, you talked very nicely, very beautiful talk, which I heard after a long time. Little bit I am away from IIP for so many reasons, but I am attending this academic session after a very long time, and please accept my compliments. You covered everything. मैं जो बोलने वाला था वो भी आपने बोल दिया. इंडियन सिनेरियो में बोलने वाला था कि वो कवर नहीं किया गया. You talked very nicely regarding what is global scenario, what are barriers, what are solutions for that, and what we can do in Indian setup. We will not go in theory, exogenous, endogenous, polygenic, monogenic, this, that, because management differs, and that is really important. Incidence of obesity, I would like to highlight one thing as far as Indian scenario is concerned. You talked regarding National Family Health Survey 3 and 4 and how it increased. There is one very specific and very good study in Tamil Nadu. Place is Pune, Mali. and they have categorically stated that overnutrition is more than undernutrition in few of the specific villages. So he said, this is the villages in Tamil Nadu, and they said that overweight children were, prevalence of overweight children were 12.6%, and undernutrition was something like that. There is some difference in that. 12.2% is undernutrition and 16.2 is overnutrition or overweightedness. This is really surprising. On one side, we are struggling with undernutrition, and now on one side we have to struggle with overnutrition or obesity. We all the time concentrate on undernutrition, all government programs, everything, undernutrition, and then marasmus, and then kwashiorkor, this and this and this and that. But unfortunately, as you pointed out very typically, obesity should be taken care of in our area. Okay, then solutions, you said something, but just 1 minute. Yes, barriers. I would like to congratulate you that you depicted that stigma in most of the rural area, and that is my experience, that they don't consider obesity as a disease. I told one of the lady that, अरे आपका बच्चा तो बीमारू लगता है, खाली उसका वजन ज्यादा है, ये मोटा है, ये है नहीं नहीं डॉक्टर साहब आप ऐसा कहते. My child is the healthiest child in my village, and she refused any treatment, she refused any investigation, and she was reluctant to go to any of the endocrinologists. So this stigma should be removed. So public education is really very important. Not only public education, let me confess very frankly that not only public education, but our medical personnel should be trained properly as far as obesity is concerned. We all the time talk of plotting weight as such. We talk of plotting height as such. But how many of us keep this? No, unforget. Forget obesity. Obesity, yes, madam, would you like to talk something? Chitra, madam? Right. Obesity.
Yes, sir. Sir,
and-
most of the pediatricians now they plot growth chart.
Yes. Yes. Maybe I am talking pediatrician like me in rural area. I'm sorry. I also keep. But as far as obesity charts are there, and we should plot. Probably Vaman Khadilkar has given these charts also. So this is one thing. Second thing, insurance. You said regarding insurance and solution. I don't think that Indian insurance companies will give insurance. Even they refuse insurance to cataract. They refuse insurance to dental surgery. Forget obesity, and they will also say that these are the healthy child. Of course, we should do something, but insurance is not a very good solution. And second thing, insurance. How many babies will need insurance? There are categories, as you know well, class 1, class 2, class 3, or grade 1, grade 2, grade 3. Only grade 3 or grade 2 with some comorbidities will need pharmacotherapy or surgical therapy. Otherwise, insurance not needed, and they are less than 1%. So that is not a very good solution as such, as far as Indian scenario is concerned. This is my view. So then, what are the solutions? And you said something, but unfortunately, proper education you depicted very nicely. But doctors should be trained properly. Why doctors are not giving lot of their attention to obesity? When, as I said, they are not keeping plots together. But most important, I would like to tell you that this is not money generating disease as such. So they don't give attention. Second thing, proper counseling is needed, which takes time. And we don't have time because we have to see 100 patients in morning OPD, 50 patients in evening OPD. And this is not right. So doctors don't spare their time. And last, let me confess very frankly, we are not properly trained. Rather than we are not confident, we are not knowledgeable regarding treating obesity. We are not trained in giving counseling to obesity. These doctors in not only in urban but rural areas should be given this counseling. And you depicted very nicely all these modalities: dietitian, endocrinologist, and then psychologist. They are not available in rural area. Yes, Bhakti.
Sir, I wanted to add one more thing that lately government has introduced those sugar boards. Like sugar board should be compulsory in all the schools, school canteens, at least so that the child or the parents should know that how much calorie or how much sugar is there in that food. Or also that jalebi and samosa, they should tell how much calories in that or
Yes,
how
yes,
much
yes, yes,
carbs
yes,
or
yes.
carbohydrate. I think that was a very
Yes.
good initiative taken by government. Uh, I hope it gets
So
continued.
I was little bit afraid, Bhakti, that you are criticizing me. अरे ये क्या बोल रहे हो, ऐसा नहीं है. But thank you very much. You have added something, and the government has taken serious cognizance of that. That is really important. So overcoming barriers is simple lifestyle changes, which I all the time advise to all mothers and babies also. Because exercise, they are forgetting exercise. Health education forget, but exercise, that is really important. Second thing, strict recording of height, weights, and so increase play time. Students, either parents don't allow or students don't want to play because one more enemy is mobile or screen timing. Of course, academic screen time is sparing up that academic screen time. Screen time should be little bit, and we should do public education for this. Just let me add one thing that in this Ganesh Utsava, I am giving some flyers. Of course, they are preparing and giving some some points to them that screen time education is really important, and that is screen time, overuse of screen time leading to obesity, dietic management you tell, and then pharmacotherapy and surgical line of treatment. Let me confess, this is not our domain. Even you told so many drugs, but I don't know anything because this is domain of endocrinologists, and they should do all these things, maybe class 2 with morbidities, comorbidities, and class 3. So these are a few of the things which I would like to tell. So these are the things what in rural area we need, what mistakes we are doing, and what we should do. Bhakti, again, congratulations. You have presented in very nice way. And thank you very much, Chitra Kulkarni, Neha, everybody, for
Yes.
giving me
Thank you, sir.
opportunity
Thank you.
to be
Thank
on
you,
this
sir, for your
academic
guidance
diet.
and support,
Sir,
sir.
IAP has also sensitized in the Upendra Kinjwadekar's tenure with
Yes,
the
sir.
SSS program, and which
Yes.
was telling what to eat, what not to eat, how to see the calories, what is the sugar content. So in that regime, I think so many programs were conducted, and
Whether
people
it's
were
for
sensitized.
pediatrician or pediatric patients.
It is directly to
It is
pediatricians. Do
it
it
is for
for
the
schools.
pediatricians.
Sir, Monty, sir, please. I hope you will not ask me anything. You will add something.
Yeah, Dr. Bhakti has dealt the subject very nicely. One thing Dr. Shekhar pointed out, every pediatrician should be like Shekhar Dabadka or say Amol and our Hemant Gangolia to spend little time with patients. To deal a child having obesity, you have to take the history, take lot of time from the parents. And the diet and counseling about the diet takes really some time. It will take half an hour at least to me. But at least we need about 15-20 minutes you have to spend with them. This much time should be devoted. And the newer drugs which are in the pipeline, one day Dr. Shekhar, it will come to our mainstream. Very fast it is in the pipeline. This orlistat is now obsolete. So there has come some liraglutide, other things have come up. What Bhakti was hinting that these medicines should be also be included in the reimbursement or in insurance also in the scheme. Like bariatric surgery, once in a blue moon somebody may need, but these medicines will be very, very commonly required in their day-to-day life, people who are really obese. That should be taken, and people like Shekhar, now this is the time to give back to the society. Be a community leader. Take up with this government, these politicians. They are the best bet. You catch hold of them. They should take as a issue. In Navi Mumbai, we conducted a survey in 2008 and 2007, 2008. We had two groups. One in the convent schools like DPS, like St. Joseph, and one group we took in the vernacular schools. To our horror, the vernacular schools obesity, overweight level is not less than the convent schools.
Yes, sir.
वो तो हमारा खाता पिता घर का बच्चा है, तो आप
हाँ
Yes.
कैसे करते हैं? खाता पिता घर का बच्चा है, गणेश जी को देख के एमुलेट करते हैं कि ये एक्चुअली दैट इज नथिंग, वेट यू शुड हैव, he is saying that you reduce like this weight, the proper diet, this should be opportunities should be taken to educate our social milieu in this direction, very much required.
Yes.
स्कूल में जो मिड डे मील बनाते हैं, प्रैक्टिकल इश्यूज, मिड डे मील बनने के टाइम में स्कूल बच्चों को दिखाओ क्या बनता है, और वो जाके घर में ये बताएंगे कि ये बना के खिलाओ में, this message will go percolate down to the social milieu. That is people like senior people like Shekhar should have a thought. You have a lot of time now. We can do many things, and hardly how much obesity, obese children we see our patients in a day, or say in a week, maybe one or two. Those category of children should be focused and follow up. Particularly tracking of their BMI is important, not the absolute BMI level. You should track them. In the growing child, BMI tracking is more important than finding out absolute BMI. That should be educated, re-emphasized. Thank you.
Yes, thank you, sir. Thank you very much for the lively discussion. And let us move on to the next topic now, which is.
Dr. Srinivasan sir raised his hand. We
Oh.
have very less time.
Yes, sir.
In 8 minutes are left and second case is there, but sir want to say something.
Yes, sir. Sir, please unmute. Srinivasan, sir, please unmute.
My school days,
Yeah.
there was a regular checkup of height, chest expansion, and other things which was done in schools. And they are plotting also. Okay. That is long back when I was in school. Okay. So I think teachers also, some physical trainer teacher or somebody must be trained. And or a school monitor in each this classroom, one boy must be trained, and then he should monitor everything. And I think that is very important because you must make them aware of their condition. Many times I see while walking children going from a school, private school, I tell the parents they are walking along with them. I said, your child is already having obesity, kindly check and then try to this thing. Yeah. Sorry, I took your time.
Yeah, thank you, sir. And CBSE schools are having all in their diary also. Let us move on to the next topic. May I request Dr. Aditya to share his presentation? Dr. Aditya, please start.
My slides are visible, ma'am. Hello, am I audible
Yeah.
and slides are visible?
Yes. Start your presentation.
Good evening, everyone. Good evening, everyone. Myself, Dr. Aditya Tam.
I
am
could
working
not
as a
see your
pediatric
slides.
internist.
Still has not come. It will take time. I
Yeah.
started screen sharing.
You
Visible?
started screen
No.
sharing. Yeah.
Yes.
Yes.
Now visible.
Go ahead. Go ahead.
Yeah.
Okay, I am taking mental impairments and positive health assessment both are childhood and adolescence.
Dr. Aditya, you can put off your video. Your audio will be better then.
Connectivity lost.
Weather problem. The next topic is also equally interesting. Dr. Aditya, you may put off your video and you can share your slides and then talk.
Visible?
No, not yet. पल्लवी मॅम तुम्ही शेअर करता का?
Let Pallavi madam share and Aditya talk.
Yeah, let Pallavi share.
Yes, sir. Sharing.
Yeah,
Sharing.
please share. Please share.
Now visible?
Not yet.
Yes, started.
Yes,
started.
yes. Now it is visible.
Okay. So I am presenting this study, the neonatal morbidities and neurodevelopmental impairments and positive health assessment in both early childhood and adolescence. This is the original article presented, published in the Journal of Pediatrics. The main objective of this study is to evaluate the health outcomes among the children who born less than 32 weeks of gestation. And also another objective is to determine whether the children positive health outcomes to children and adolescents. They studied the 3 neonatal morbidities, that is intraventricular hemorrhage, bronchopulmonary dysplasia and IVH, and 2 neurodevelopmental impairments. And also they compare these babies without the children without these exposures and impairments. So, in introduction, I will like to tell that Elgan is the extremely low birth weight, extremely low gestational age newborn, less than 28 weeks. In this study, they found that the children, the 10-year-old boy, which was born extremely preterm, who had bronchopulmonary dysplasia and had lower scores on assessment of health-related quality of life. Also, they found that the quality of life is lower among those with neonatal morbidities and developmental impairments. The researchers among the ECO, that is National Institute of Health in Environmental Influences on Child Health Outcome Program, initially they studied the children among the 5 to 9 years of age, and later on they studied the children among 8 to 17 years of age. Those in their study, they found that the chronic illnesses had lower general health. The only factor associated with lower positive health scores were the chronic pain and depression. The method used in this study, they used the prospective study and they used the 3 cohorts. The Elgon score, that is extremely low gestational age neonates, which are born between 2001 to 2004. Second cohort is developmental impact of NICU exposure cohort, that is DINE cohort, born between the 2020 and 2020. And third cohort is NOVI cohort, that is neurobehavior and outcomes in a very preterm infant cohort, the birth year between the 2014 and 2016. Later on, they found a relationship between the 2 groups, that is 2 neonatal exposure groups, that is the morbidities identified before hospital discharge and developmental impairments identified before 3 years of age. The morbidities identified before discharge in neonatal groups and developmental impairments. The another group is outcome groups. They again found a relationship between the positive health scores reported by patients in the early childhood, that is preschool age, and positive health scores reported by children at adolescence, that is filled by children only. Initially, the original sample size was about 2560, but because of some dropouts, the final sample size was 1368. Among that, 747 are Elgon cohort, 447 were NOVI cohort, and 174 was DINE cohort. In that, they had done the measurements. The neonatal measurements include one or the following diagnosis. I am not going into the details of BPD definition and necrotizing enterocolitis and IVH. They include the neonatal exposures for the 3, that is bronchopulmonary dysplasia, necrotizing enterocolitis, and intraventricular hemorrhage. For this, they collected the data from the child's birth medical record and from cohort specific forms and later harmonized into a single database. The outcomes, they include the global health, life satisfaction, meaning and purpose. For outcomes, they use the PROMIS questionnaire, that is patient reported outcomes measurement information system. The PROMIS scores that they will get, scores used using a standard T-score metric. Then the parent proxy questionnaire was collected from the DINE and NOVI cohort during the early childhood, that is the preschool age, and pediatric self-limited questionnaires were collected from the Elgin cohort, that is during the adolescence. The potential predictors, the exposures in this analysis was the severe or moderate neurodevelopmental impairment or any diagnosis of cerebral palsy. The potential confounders found during this study was sex at birth, gestational age, birth weight, maternal education, maternal age at child's birth, and 5-minute Apgar score and maternal receipt of antenatal corticosteroids. The data from the patient's medical record and from maternal interview in Novi and Elgin studies, and by extraction from the obstetric record and maternal interview in the dying study. Later on, the statistical analysis of this include, first of all, they describe the characteristics of the sample, that is the frequency of neonatal morbidities, neurodevelopmental impairments, and distributions of positive health scores among children born less than 32 weeks of gestation. They use the Akai and Bayesian criteria for the statistical analysis and to select and retain the statistically important predictors for each step in the regression model. The threshold for retaining and removing the predictors from the model was a p-value less than 0.5, and R-square statistics was calculated to determine the variance of potentially important covariates for each positive health scores. Then in result, the regression model was used for association between the neonatal morbidities and positive health. First of all, neonatal morbidities and life satisfaction. In this study, it was found that the bronchopulmonary dysplasia and necrotary enterocolitis has life satisfaction scores that were no different at early childhood and child without these morbidities. Means there is no difference between the child without these morbidities. Then third, exposure is intraventricular hemorrhage has slight lower life satisfaction score at early childhood, but in later adolescence there is no difference in the life satisfaction. This is again the same regarding the bronchopulmonary dysplasia, necrotary enterocolitis and IVH. The second, they found the association between the neonatal morbidities and global health. The bronchopulmonary dysplasia has slightly lower global health scores at early childhood than those without history of bronchopulmonary dysplasia. There is no association between the bronchopulmonary dysplasia and global health at adolescence. And again, no significant difference in the global health scores, those with or without prior diagnosis of necrotizing enterocolitis and IVH at both early childhood and adolescence. Means only they found association during the early childhood in the bronchopulmonary dysplasia. The third is neonatal morbidities and meaning and purpose. The adolescents who were previously diagnosed with bronchopulmonary dysplasia, NEC and intraventricular hemorrhage has global health scores that were similar to those of children without these morbidities. Means there is no significant difference between the children without these morbidities. Then they found the association between the neonatal morbidities, developmental impairments and positive health. The developmental impairments and life satisfaction, there is no association between the neurodevelopmental impairments and life satisfaction scores during the early childhood. Secondly, the cerebral palsy was associated with a small significant increase in the life satisfaction scores at adolescence, but not in the early childhood. The second association is developmental impairments and global health. The children with cerebral palsy had lower global health scores during the early childhood than those without cerebral palsy. But among in adolescents, the diagnosis with cerebral palsy were similar to those without diagnosis of cerebral palsy. So no significant relationship were found between the functional, cognitive and motor function and global health either during the early childhood or adolescence. The third is developmental impairments and meaning and purpose. The cerebral palsy associated with higher T-scores differences for meaning and purpose during the adolescence. So mainly the strength of this study is to potential value of research on positive health being such as well-being, resilience and capabilities. In this study, we are able to find that bronchopulmonary dysplasia has lower positive health scores in early childhood and bronchopulmonary dysplasia had similar scores in the adolescents. Then secondly, the necrotizing enterocolitis has no significance, no difference during the early childhood and also during the adolescence. The third exposure that was studied is the intraventricular hemorrhage. Also, intraventricular hemorrhage has lower positive health scores during the early childhood and similar positive health score during the adolescence. Later on, the cerebral palsy also has lower positive health score during the early childhood and similar positive health scores in the adolescence. The cognitive or motor impairments which were studied has no significant difference in the positive health scores during the early childhood or adolescence. So mainly the strength of the study is it is a large multi-center cohort which are collected from the 3 different centers and they included a very preterm infants which were born to evaluate the neonatal morbidities and neurodevelopmental impairments and positive health indicators in a single multi-center analysis. In this study there is separate analysis of parent proxy and child reported data. The main limitation of this study is that it is not adequate for the contributions of IVH and cerebral palsy from outcome positive health due to the high levels of overlap between these 2 outcomes. Also, the study is unable to make within the subject interferences about the progression of positive health between the early childhood and later on adolescence. Also, some childs are not able to complete the PROMIS questionnaires due to the cognitive and motor impairment that is in the cerebral palsy patient. Then another limitation is findings at adolescence may be less recognizable, generalizable than the findings from the early childhood. So the further scope of this study is repeated measurements of neonatal morbidities and neurodevelopmental impairments has positive health assessment in both early childhood and adolescence. And also the age group can be increased as they have only taken less than 32 weeks of gestation. They can take, we can further add on this study more to 40 weeks. Suppose the baby has suffering, the term baby was suffering from the birth asphyxia. So also in further course of life, the child may suffering from the cerebral palsy. So these patients were not included. So again, we can further add on this study to increase the age group. So basically, this is the study which was done to sensitize the pediatrician, neonatologist, and young intensivist, so that only our job is not limited to the ICU or only managing the intensive care. It was apart from that intensive care, how the child was doing well in further life and how the child was emotionally, mentally, physically healthy in the further life. So the further scope of this study is the behavioral therapy which we can include in this study and physiotherapy. That's it from my side, sir.
Thank you so much, Dr. Aditya. It was a nice presentation. And let us hear from the expert now. Dr. Amit, over to you, what you are doing in your practice.
Good evening, ma'am. Congratulations, Aditya.
Thank you.
Am I visible?
Yes.
Yeah.
Please stop sharing, Dr. Aditya, please. Yeah, thank you very much.
It was a complicated article. So Aditya has done a good job to do this. But whenever we read some journal article, we should read it carefully and in between the lines. Now, if we look at this article, the first and foremost thing, the limitation that they did not mention, this was not a trial with a primary follow-up study. So this was a pool data. And that pool data was from 3 different cohorts spreading over 20 years. Now, 20 years from 2000 to 2020 is a big period for neonatology because so many things changed during that time. The coverage of anti-steroids changed, the coverage of surfactant, the ways of giving surfactant, the methods of ventilation, the finesse of ventilation, the advent of better high-frequency ventilators, advent of nutritional interventions, advent of thermoregulation, So there are so many things that changed over these 20 years. Now these three cohorts were also not the cohorts with a follow-up purpose. So they had different, like one, now if we take the DINE one, so DINE had 4 different trials involved. So they were all patients being followed up in some program and the data was pooled. Now, as Aditya mentioned, almost half of the patients were lost. Now, if it is a primary follow-up trial, not more than 10% dropout is allowed. Here we see almost 50% dropout has happened. Now that dropout has happened exclusively from the DINE group, mainly from the DINE group. Now the basic reason is none of these trials were follow-up trials. Those babies from certain different cohorts were followed up, and because the follow-up data was available, it was pooled together. Now there is something called parent reporting, which has happened in early childhood, which is somewhere around 5 to 8 years. And there is something called self-reporting, which has happened in adolescents somewhere between 10 to 18 years. Now we have to understand one important thing here. These are not the same patients where parent reporting was done and adolescent reporting was done. So parent reporting happened in the DINE and NOVAI because that follow-up was happening at early where parents were reported. Now perspective of a parent will be different. If we see in that, a parent is more worried about the health issues. Now the BPD has become a significant factor there because at that age group, the respiratory difficulties, hyperreactive airway disease become very common and troubling for the parent. Now, what I think about my child's life expectations and what my child thinks about his own life expectations will be different. That's why parents' interpretation will matter only if the same group is for adolescent reporting. Now that has not happened. The adolescent reporting has happened in Elgin group. Now that is the reporting done by kids whose parents have not reported. So we can't compare because it's not a temporal correlation. These are two different. So we can't say that there is an association between that early childhood morbidity and the adolescent reporting. So they are two different things and they can't be correlated. They are two different altogether groups. They are different to altogether assessments and they are different to altogether reporters. So everything has happened differently. So there can't be any correlation between these two reportings. And the most important thing that we should understand, if we look at this, it feels like saving these extremely preterm babies is a fantastic thing because the life quality is so good. Now we have to understand one important thing. This was a comparison between preterm babies with morbidities, those 3 morbidities they had considered, and preterm babies without morbidity. They were all preterm babies from these 3 cohorts in follow-up from 6 different trials. There was no healthy control. So what we are saying that the BPD had early problem, did not have any adolescent problem. IVH had life expectancy issues or life quality issues. This was all compared from one preterm to other preterm. So preterm with BPD or IVH or NEC stage 2 and above, and those preterms who did not have any of these. So they were preterms compared to preterms. They were not controlled with healthy term babies. So that's why we feel that this is a very good data or it's a very good outcome, but it is compared with preterms and not with the healthy terms. Whenever we talk in our follow-ups, we always talk about healthy controls. Now, healthy control will be the person, like the definition we all know, it should be full term, more than 2.5 kg, no significant perinatal issues, no significant maternal issues, all those. So, but with common social background. So I think it was a very complicated data. It was a pooled data. Now, if we want to apply this to India, the best available cohort in India is the Pune low birth weight study done by Sudha Chaudhary ma'am. I am fortunate to do my neonatology dissertation with her. It was a long-term outcome of less than 1,000 grams babies. And my pediatric dissertation was long-term outcome of less than 1,500 grams babies. So the whole of my dissertations were on developmental follow-ups. So if we look at the cohort that we can see in India, the Pune low birth weight cohort, which was followed, cohort was done, and it was followed up to almost 22 years. And it was published at 2 years, 18 months, 2 years, 3 years, 6 years, 12 years, 18 years, and 22 years. Now, if we look at that, why I'm telling this? Because in this cohort that we have seen, it was preterm to preterm. We did not have a healthy control. Now, if you look at the 12 years follow-up or of the Pune LBW cohort, which was all babies less than 2,000 grams because it started in 1988. It was published in Indian Pediatrics 2004. The IQ of a preterm was 89.5%, which was good. 89.5 is good. But compared to control, the median IQ of a control or healthy term babies were 97.2. So compared to control, the IQ of a preterm baby was low. A low birth weight baby, significant figures. So IQ, though normal in low birth weight, is lower than controls, healthy controls. What we call a bright kid, only 3.3% of the low birth weight were bright compared to 22.2% of healthy terms. Mental retardation was 15.4% in low birth weight compared to 3.3% in terms. So when we compare it to the terms, healthy terms, then the data doesn't look that good, but it is really fine. Now at 18 years, the IQ was still lower than controls and it correlated well with the 6-year and 12-year IQ. So this article that we discussed was a pooled data of follow-ups. And in those follow-ups, they retrospectively found out which babies have
Dr. Amit, you are not audible. Yeah. Amit sir is having some issues probably with connection.
Can sum up.
Yeah. Sum up, sir.
now these three morbidities and what is the correlation. So looking technically,
Dr. Amit? Dr. Amit, you are not audible. Yeah, there is some technical issue probably. Dr. Nimen sir, yeah.
So,
am I audible
Dr.
now?
Amit, yeah,
now,
yes,
yes,
you are
he's
audible.
now. Yeah,
Yeah.
please go ahead.
Yeah,
Yes, sir.
you were talking about the study.
Please go ahead.
Yes, sir.
You're audible.
Yeah.
Yeah. So this is overall a good article because it gives us idea about the expectations of a kid and parent and a big number of participants. Well, the way it was done, like the assessment done was well designed and bit complicated, but it was nice trial and Aditya did it very well. Thank you.
Yeah, sir. Nimen Mohanty sir, your comments.
No, there is, I think nothing to add. Dr. Aditya and Dr. Amit have done the best. In this article, definitely it is a complicated article. But why we have chosen this article is because of the number, the size of preterm babies and variety of comorbidities, and they are followed. They have followed up this with comorbidities preterms and preterms maybe without that particular comorbidities. They have shown that because it is a retrospective study, they could not enlist the term babies. We should now think about conducting such studies in our setup, maybe including the late preterms also, that we can see what it comes out to be. This study, all articles are not ideally excellent. Some articles are deliberately chosen having some adverse things. So this is pointed out and discussed. See, Dr. Amit has rightly pointed out the discrepancy in finding control. So these wherever there is a shortcomings, these should also be brought out for discussion. And Dr. Amit, Dr. Aditya, they have done very well. Congratulations to you.
Thanks, sir.
May I invite our scientific convener, Dr. Minhas sir, for his comments? I could not find, has he logged in? Dr. Minhas?
He is not senior.
Yeah, not seen. Okay, any question and answers from YouTube, Pallavi?
No, ma'am. No.
Okay. Shall we conclude, sir?
Yeah, please.
May I invite Raigad IIP Secretary, Dr. Koli, for vote of thanks?
He is not there, madam.
Yeah, that I could see, neither Dr. Neha. So let me thank everyone for this interesting discussion about obesity as well as neonatal morbidities. I immensely thank Maha IIP President, Dr. Sanjay Pakmode sir, who always be present here for our article. Thank you, sir. Whatever day and how much busy he is, I immensely thank Dr. Sanjay Pakmode sir for being present in all Journal Journey episodes. Also, we are getting blessing of Dr. Srinivasan sir for this episode. Thank you so much. Our guide, Dr. Nimen Mohanty sir, past Maha IIP President, Dr. Hemant Gangolia sir, our Bhishma Pitamaha of Raigad IIP, and this time's expert, Dr. Shekhar Dabadkar, our second expert who has given very nice comments about the research article, Dr. Amit Tagare, presenters, Dr. Bhakti and Dr. Aditya. Thank you very much. We also thank Pallavi Dharmadikari ma'am and Dr. Vishal Raut, Dr. Neha Singh to make this happen. Thank you very much. And